Hello, good afternoon. We are very excited to host Dr. Betsy Cliff today. Dr. Cliff joined the University of Chicago's Department of Public Health Sciences in 2022 from the University of Illinois at Chicago School of Public Health. Her work investigates whether treating individuals as consumers who make price and value judgments about their medical care leads to improved healthcare quality and more efficient spending. With a primary focus on health insurance benefit design, she examines its influence on spending behaviors and care utilization. Her expertise lies in health services research, emphasizing economic theory and methods, and she employs quasi-experimental research design alongside advanced econometric techniques to assess policy impacts. Prior to getting her PhD, she was also a healthcare journalist, so she brings a wealth of expertise to the topics that she studies. So please join me in welcoming Dr. Cliff today.
Hi, thank you so much for that lovely introduction, Shelby. I'm really thrilled to be with you all today. This project is something I've been working on for a few years, and it's a little, usually if I was up here talking to you, it would be about health insurance benefit design, but this is a little bit of a departure. This is a project I've been working on looking at a specific population, but still looking at how health insurance transitions and how those transitions impact a particularly vulnerable population. So this project is called Lost in Transition. This particular part of the project is about disenrollment from Medicaid among young adults with complex medical conditions, and we'll talk about what each of those terms means. I am the PI on the project. I'm also working with a number of other researchers, Dory Cross at the University of Minnesota, Erin Hickey, Rachel Caskey, and Christy Kirshner, who are all medical physicians at University of Illinois, Chicago, and a couple of students here at the University of Chicago, one of our doctoral students in public health sciences, Soham Sinha, and Ria Shah, an undergraduate at the college. This project is funded by the Robert Wood Johnson Foundation and by the Lucille Packard Foundation for Children's Health, and the usual disclaimer applies. They are not responsible for the content of it. Okay, so jumping right in, when I say young adults with complex medical conditions, what do I mean? This is here we're talking about a population. You can talk about, obviously, individuals with complex medical conditions are the portion of the population that we think is sort of the most seriously ill. So we often talk about children with special healthcare needs or children with medically complex conditions. We're talking about the approximately 3 to 5% of the childhood population with a congenital or a significant illness that begins at a young age, and that often affects multiple organs and affects somebody's daily functioning over a long period of time. So this is distinct. Yes?
All children or children in Medicaid?
All children. So yeah, and thank you. I should have mentioned at the beginning, I'm happy to answer any clarifying questions. If you have sort of more substantial points of discussion, maybe save it to the end just to make sure we get through everything. This is distinct from chronic conditions. So the estimate is that about 25% of children have a chronic condition. This would be a very small subset of that. And these are, from an economic standpoint, health economists like myself often talk about the skewedness of healthcare spending, where there's a very small percentage of the population that spends most of the money in healthcare. This is that population. So this is the population that has multiple specialists, multiple doctor's appointments, maybe even multiple inpatient stays in hospitals in a year. And often this population relies on either technology or significant home-based supports. So the title of this slide is Medical Success and Health System Failure, which I think describes actually a lot of healthcare. But in this case, what I mean here is that this is a population that maybe 50 years ago or so, or even more recently, a significant portion would have died in childhood because we just didn't know how to treat them very well. Medical technology and medical knowledge has advanced so that now about 85% of children classified as medically complex live into adulthood, but the health system and the support systems haven't necessarily caught up to support people past childhood. So this is what advocates for this population often call a disability cliff, where you have a relatively more generous support system up until people turn 18, and then it sort of caverns out, and in adulthood, there's fewer social supports. So specifically, what do we mean? We're going to be talking about Medicaid here as a key social support. Why Medicaid? Well, Medicaid is the primary payer for about half of children with medically complex conditions. So that means it's, not only paying for some of those home-based and technology supports that I mentioned, but obviously all of the population's medical care, specialist, primary care, all that. Eligibility for Medicaid, and we'll talk a little bit more about this, changes at age 18 or shortly thereafter. And as many of you already know, losing insurance can cause a cascade of other disruptions in care. For this population, and actually for the population, the general population, there's not a lot of information about how many people disenroll right at this transition between childhood and adulthood. It's actually amazing if you go and look at the literature. It's fairly siloed into up to 18 and then 18 to 64, but there's not a lot around the transition. So that's what we're going to be looking at here. We're going to be looking at, as people transition to adulthood, what is their rate of disenrollment. We will be focusing on this particular population classified as medically complex, but we'll actually be able to generate estimates for the non-complex population as well. And then we'll be talking about how that varies by the specific complex condition that a person has been diagnosed with. And because we have a national data set, we can show variations by geography as well. So that leads into the presentation, the rest of the outline for the rest of the presentation. I'm first going to give you a little bit more background on this population. We're going to talk about the motivation for this study, and then go through sort of the general data methodology, results, and discussion. So what is Medicaid? I said that this is the population that we're going to be studying. People in this room probably don't need too much of a primer, but just so that everybody's on the same page, Medicaid is the safety net health insurance for the United States. It generally covers people with low incomes and also has disability criteria that you can qualify for insurance for, but is I think in almost every case means tested. States run these programs and certify that somebody is eligible and recertify eligibility as well. And income thresholds vary by state. After the Affordable Care Act, many states use the 138% of poverty eligibility threshold, but I think about 10 states haven't expanded Medicaid at this point, and so eligibility thresholds would differ in those states. If you are in Medicaid, most services are covered at low or no cost, but the comprehensiveness of what services are eligible for Medicaid coverage varies state to state. Okay, and then just to sort of situate you in where Medicaid falls within the sort of general health insurance scheme in the US, I actually gave this presentation internationally last week, and so had this slide for this, but people liked it so much that I kept it in. So this is a slide I made off of 2022 numbers. The population of the United States is about 330 million. I hope you can see the numbers in the back. Of that 330 million, about 58 million are over age 65 and so have Medicare as their primary insurance. About 10% of that 58 million also have Medicaid. About 9 million get insurance through the military. And then the bulk of the population, those people under age 65, get health insurance from sort of a myriad of different sources, depending on where you work, how old you are, and what your income is in general. So of the under 65 population, the bulk are getting their insurance through employer-sponsored coverage. About 80 million are getting their insurance through a public plan, either Medicaid, so that's 69 million people in the United States, or Medicare, 8 million people. About 33 million in 2022 are still uninsured. And then a smaller portion are getting their insurance from non-group coverage, which again can come from several different sources, or are institutionalized. So that's in sort of prisons or maybe long-term, some sort of long-term care, long-term psychiatric care. One thing I want you to take away from this slide is how fragmented health insurance is in the United States. So there are any number of life events that can happen to a person that can, particularly for the under 65 population, shift which bucket you end up in. So just as an example, I have a son, he's 15 years old. He's been in employer-sponsored insurance, in public coverage, he's been uninsured, and he's been in non-group coverage in just 15 years. So what are the reasons that somebody might be forced to change, to switch health insurance? Well, you could be diagnosed with a condition. For example, people with end-stage kidney disease are eligible for Medicare automatically. You could have family size changes. You could change where you live. Any number of things could change with your job. If you change jobs, if you lose a job, if you reduce your hours on a job, if your employer decides to change which healthcare plans are offered. All of those can result in a change in health insurance. I'm sure if we took a survey, many of you in this room would have been forced to change your health insurance at some point in your life. A change in income can also cause change in health insurance. And this one that we're going to focus on is that if you have a birthday, that may force you to change your health insurance as well. So within Medicaid, why would a birthday be a cause for a change in health insurance? So the specific birthdays that we're going to be concerned about are right around that transition to young adulthood, as I said earlier. What happens at that point? Well, at age 18, that's the last year that parental income is used to determine eligibility for Medicaid. And that's also the age at which supplemental security income is redetermined. SSI in most states makes you eligible for Medicaid. So if you become ineligible for SSI, that can affect your Medicaid eligibility. At age 19, then you qualify as an adult. You need to qualify as an adult for Medicaid. In states that have not, that may mean new criteria, particularly in states that haven't expanded Medicaid and so have that sort of baseline 138% of poverty. And then at age 21, there are some ways that some states will extend eligibility for certain conditions under what are called 1915C waivers, but many of them have 21 as sort of an ending threshold. So at age 21, that might be another point where people could get dropped from health insurance. Okay, and then also just to say that this is also, we're going to be mostly talking about health insurance, but of course this is an age where there are a lot of other changes or potential changes in people's lives. They may, and within the healthcare system, this is an age at which you transition from pediatric to adult healthcare providers. And then socially, there's a lot going on too. People and public schooling, they may move out of a caregiver's house, they may move to a different state or a different city. There has been a fair amount of research, particularly some of it seems, it's kind of waned, it seems like in recent years, but people have looked at whether during this transition to adulthood, what happens, and particularly what happens to people with medical complexity. So a study from 2006 found that among youth with disabling conditions, about a quarter were uninsured. Of course, this is prior to the passage of the Affordable Care Act, so those numbers may not hold now. And also that more than a third prior to the Affordable Care Act lost insurance during this transition to adulthood. Then there's been studies that have looked, and these both use survey data, studies using administrative data, which may be a little more accurate sometimes, have looked at specific conditions that would be classified as medically complex, including autism and intellectual disability, and also found that a significant number lose insurance during that transition to adulthood. And then there's been some studies looking at what helps people retain coverage, finding that specific eligibility pathways, such as the disability eligibility pathway, have increased retention in Medicaid. But again, A lot of these studies are pre-ACA, and so it's not necessarily clear how well they apply to sort of the current landscape. And then why do we study losing health insurance? I probably, again, with this audience, may not need to go through it so much, but gaps in health insurance have been linked through a pretty robust literature with a decline in the use of preventive care and with worse disease outcomes. When Sebastian Tello-Trillo was here a few weeks ago, he talked about the loss of insurance is associated with lower health status, lower hospital use, and lower use of substance disorder treatment. And then there's also a second, there's a literature specific to medical complexity that looks at exacerbations of whatever condition right around this time period, and have found that there is exacerbation. Often people with medically complex conditions have exacerbations of their condition or even increased mortality right around this late teens to early 20s period. They haven't necessarily linked it to insurance, but it certainly could be a cause. And finally, just to sort of bring what insurance means to families with children with medical complexity sort of down to earth, I wanted to show you this slide that has a diagram that a mother of a child with medical complexity made. And it shows her family. I don't know how well you can see this in the back, but that center node says our family. And then each of these color-coded things is a different sort of system that they need to work in and the different supports that help them within that system. So, this red over here, the red is school, this blue is advocacy, and the dark blue at the bottom is health. Sorry, I'm trying not to move too much from the microphone. But you can see Medicaid is right at the top there, and it's sort of feeding into all these other specialists that they need, including dentists, primary care pediatricians, specialist pediatricians, psychiatrists, all the other. So that's just to show you that sort of if you think about removing that key piece, Medicaid, this whole web, and particularly the web around health, could be at risk. So before I get into the data source, I wanted to talk to you about that's sort of the national picture that motivated us. There was a second motivation as well, which was closer to home. And this is particularly with my colleagues at UI Health. They were concerned about this population. They were seeing a lot in the hospital. And in 2019, they started exploring this idea to better serve the population of adults and young adults with medical complexity in Chicago. So this study, while it is national in scope, was precipitated by their experience at UI Health and by looking at data. This is just in Chicago, looking at hospital admissions for medically complex patients in Chicago. It's some work that we did in 2019. And what you can see from this data is that total admissions declined from age 18 through about age 23, 24. Then there's sort of a slight uptick, but a general decline from age 18. And Medicaid admissions decline as well. So we don't necessarily think that these patients are getting healthier in that time. What we think is that they're just less likely to access care. And that was supported by the experiences of the clinicians on our team. They met with patients who described difficulties in accessing care during this transition. They had heard from patients a lot of uncertainty around coverage, around providers. And these personal anecdotes sort of motivated us to look more closely at what is happening. We actually first started to look just in Illinois, but it ended up being easier to get data at a national level. So just to sort of, this is just to remind you what the research question is here. We're going to, there's very little national information or Illinois-specific information, especially post-ACA, on the level of disenrollment in Medicaid among adults as children transition to young adulthood. Most studies are currently condition-specific, and there's pretty much no information or no information we could find on variation among states. So that led us to this study. We're going to move into the data and the methodology. Okay, so the goal and what I'm going to be talking to you about for the rest of the presentation is that we're going to estimate the likelihood of disenrollment from Medicaid from somebody's late teens, beginning at age 15, up through their early 20s, ending at age 25. And then we're going to estimate the differences in among what type of, I say body system here, but really what I mean is what type of chronic condition or complex condition you have. And then we're also going to look at variation among states, and we'll have some preliminary information on state-based characteristics too. So the data we use for this are the TMSIS analytic files, or sometimes called the TAF files. This is the census of US Medicaid enrollees from 2016 to 2019. This is an administrative medical claims database. We're going to define a cohort in 2016, so I'll show you some data that's just from 2016, and then we're going to measure their likelihood of disenrollment in 2017, 2018, and 2019. So here's information from 2016. This is how we created our cohort. We first pulled all enrollees who were born between 1991 and 2001. So this is ages 15 to 25 in 2016. We kept enrollees who had eligibility for 11 months. And the reason we did that, we do lose a lot of sample and some generalizability that way. But we need people to have continuous enrollment in order to be able to use the claims to measure chronic conditions, because you need to have a claims history to find people, with complex conditions. We were unable to include Maryland, Arkansas, and Georgia because they didn't have reliable enough claims or admission dates. We don't have Medicare claims, so we actually exclude dual eligible enrollees. And we exclude enrollees who have more than one state identified in a year because we're not sort of entirely sure that we have it's a very small percentage, and we're not sure that we have reliable data for them. So our final sample is about 9.3 million people. And then from that, what we do, so then we can look at the percentage of people in each state who are enrolled in Medicaid. So you can see here it varies by state from less than 12% of the population to, I think New Mexico has the highest, with 45% of the population ages 15 to 25 enrolled in Medicaid. So of that 9.3 million, they're not geographically dispersed equally, obviously, both based on even conditional on differences in state populations. Some Medicaid plans are much more generous than others and enroll a higher percentage of this 15 to 25-year-old population. Okay, so now then turning to how we defined medical complexity. There's a lot of ways to define it in general, and there's no sort of agreed upon definition. There's not even, but what we attempted to do is define it through the medical claims. There's not even an agreed upon definition within the medical claims. So we picked an algorithm that we felt like best represented our population, that had been validated in the population at least up to age 18, and that had some information about overall prevalence. And that algorithm is called the Pediatric Medical Complexity Algorithm. The way it defines medical complexity is that a person has a chronic condition that in 2 or more body systems, or they have a progressive health condition, or they have a childhood cancer. So just to give you an example, this would include people with cystic fibrosis, would include people with sickle cell disease, would include people with autism if they have another condition in addition, would include people with type 1 diabetes if they have another condition in addition to that disease, would include people with severe mental illnesses if they have, again, another condition in addition to that. Previous research has shown that if you use the Pediatric Medical Complexity Algorithm, it classifies approximately 5% of children as being medically complex. That would translate into about 4 million kids in the United States. So when we use the pediatric medical complexity algorithm on our population, what we found is that about 3.8% of our population was classified as medically complex. That's 352,710 people in Medicaid between the ages of 15 and 25. And you can see, the other thing you can see on this table is that the prevalence increases in age. So that's, and that the number decreases in age, right? So you have more people who are ages 15 to 18 in Medicaid compared with people who are ages 23 to 25. That generally reflects attrition from the program as people get older. And then what it also reflects, because this prevalence is increasing, is that it's likely that people, will test it more formally, but this suggests that people with complex medical conditions are less likely to attrite from the program than people without them. We have about, in younger ages, slightly less than half identify as female. There are more females as you get into older ages. This may have to do with eligibility during pregnancy. And then about the same, there's really not huge differences in the zip code level, median income, or education levels between enrollees with complex and medical conditions and the non-complex population. So here's, like I said, when we went through the algorithm, which body systems, you needed 2 or more body systems, or you also, an enrollee could have a progressive or a malignant condition. You can see progressive is one of the most common in this population. The other really common condition is a mental health condition. That needs to be in combination with some other condition. Neurological is the second most common. So a lot of the enrollees that may be flagged are somebody with a neurological condition like autism and a mental health condition, maybe depression or anxiety or any other mental health condition. And then the others have a lot lower prevalence in this population. So this is a graph similar to before. The other one was just the general percentage of people ages 15 to 25 in Medicaid. This is the percentage of Medicaid enrollees with complex conditions. So you can see it, should have maybe put the maps side to side, but in general, states that have a higher prevalence of general enrollees have a lower prevalence of people with complex conditions because the generosity, it reflects the generosity of the Medicaid program in that state for the general population. So states with fairly restrictive Medicaid programs like Texas, Idaho, Oklahoma have a high prevalence of people with complex conditions. Again, reflecting that that without those, people have a harder time qualifying in those states. Although it's not across the board, right? Like you can see, Minnesota is generous, has actually a fairly generous Medicaid program and also has a high prevalence of people with complex medical conditions, reflecting that states can make both, it's not an either or, states can make both things true. A generous program and make it easy to qualify for people with complex medical conditions.